I'm Marvin Malik, and I'm going to introduce the topic of pharmaceutical industry, highlight its importance, and discuss the approaches we'll be taking toward this topic. And today, in particular, I'm going to discuss the Medicare Modernization Act of 2003, which was the act that provided a drug benefit which within the Medicare program. Medicare had existed for 38 years with no help on prescription drugs, which back then were, many of them were extremely expensive. And the problem of extremely expensive drug is way worse now than it was then. I've encouraged all of you to read the book, The Truth About the Drug Companies by Marcia Angel, the former editor of the New England Journal of Medicine for several years. And it's a superb book, beautifully organized, easy to understand, and extremely insightful. It's a superb book. It has a huge defect, though, and that is that it was published in 2004. And I wish somebody would write a book to sort of update it. Frankly, unfortunately, I don't think they would need to change very much. But the one big change is that the opportunities that the pharmaceutical industry has, which have never been restricted to just raise prices as much as they want to, has been mega exploited to much greater extents over the last 20 years. I actually don't know why they didn't do it then, or why I think they're going to do it as long as they get away with it. So I just wanted to point that out. It's such a great resource, beautifully written book. And it's, as I said, it's all still largely true. So what we've got is a session tomorrow on research and strategies the pharmaceutical industry has to get drugs approved, even though they may not be really better than what's already on the market, and all the strategies they use to get people to buy drugs that may not be especially useful as well, and maybe even don't work. So Dr. Joel Lection, a renowned pharmaceutical researcher from the University of Toronto, will be here to talk about that. And by the way, he'll be returning for the very last session on this pharmaceutical industry to discuss the Physicians for National Health Program recommendations for how to reform that sector, how to reform the pharmaceutical sector. He actually worked on it, and the recommendation applies to Canada as well, but the bigger part of it is the US, since our population is 10 times larger. Anyway, and then later tomorrow, Nirali will be doing a presentation on pharmaceutical industry marketing and promotion and its activities to infiltrate many sectors of the healthcare sector to achieve their ends. Next Monday, there'll be a session on pharmacy benefit managers, that whole sector, how they work, how they end up raising drug prices and making massive profits. Astonishing. It's a sector nobody knows about, but you will by the end of Monday. And a wonderful woman named Shannon Rotolo, who's part of Pharmacists for National Health Program. She'll be doing that talk. Tuesday morning next week, Ken will be doing a long talk on patents and their abuse, and some of the other legal aspects, like the interaction between the Food and Drug Administration, which regulates whether new drugs can be allowed to be done. He'll talk about that as well. And then, I'm sorry, I left out Monday morning, Dr. Weisbart will be talking about formulary development, how you decide which drugs are going to be in a formulary, why you want to have a formulary for a national health program. And then, as I said, Dr. Lection will be back to discuss the PNHP proposal. So let me share a few slides. So I'm going to talk about Medicare Modernization Act of 2003. It actually had a longer name, but that people refer to it this way. And I just want to say that the word modernization is very political in a sense, and I'll get to that in a minute. In terms of drug spending, you can see that the United States has had tremendous increase in drug spending between 1990 and 2018. It's continuing to increase since then. Our per capita spending on prescription drugs is higher than any other country by a lot. And this is both because we use more drugs, our volume is higher, and the prices are higher. And especially number two, the prices are very high in the United States. And as we pointed out earlier in the internship, this is one of the top 5 slides I encourage you to use. It'll be updated presumably, and um, no longer need to use the 11-year-old version. But things aren't getting better. Income and wealth inequality in the United States is becoming more dramatic. So anyway, so many people cannot afford to pay $180,000 a year for a drug, or even if they were in Medicare and had a 20% copay on it or whatever it would be, people just can't afford that. 60% of the population has that year had less than $16,000 disposable income. So maybe it's up to 22,000 by now, but doesn't get you even that one drug that I was describing. So in response to this, there were efforts to create a way to cover prescription drugs. And in reality, this followed years of advocacy, especially by seniors groups, to get a benefit into Medicare. At that point, people under 65 generally already had a prescription drug benefit. Typically, that benefit had meaningful deductibles and copays. So interestingly, in 2003, the Republican Party held both houses of Congress and the presidency. More on that in a second. But going back a little further, there had been many efforts in the U.S. Congress to enact a prescription drug plan, and that the first one of those was in 1989, when it was combined with a catastrophic benefit. And one of the probably the biggest failing within Medicare is that you literally have unlimited costs. The sky's the limit. You get into 20% co-insurance in Medicare Part B by itself. There's no end. You keep paying the 20% until you get to infinity. So they wanted to have a catastrophic benefit so it would stop at a certain point. You've spent $2,000 or $6,000. I actually don't remember what it was, and then you're done paying if you're in Medicare. A desperately needed thing. And they combined a drug benefit with that, and it didn't pass, and it was hated. And I don't remember all the reasons for that. I think it might have been maybe too progressive, that rich people didn't want to do it. I can't remember all the reasons. Part of Clinton administration's big package, which was sometimes called Clinton Care or Hillary Care because Hillary Clinton was so involved, that failed in 1993, and as part of that massive piece of legislation, there was a drug benefit, which didn't make it either because the whole plan failed. Clinton made 2 more attempts in 1998 and 1999, and by that time, a fellow named Newt Gingrich had been elected in a district in Georgia to the House of Representatives, and he basically said that we're not going to let Clinton do anything for the entire remainder of his presidency, so that he can be regarded in retrospect as a failed president. He stated that publicly and carried it out. And that was really the beginning of our current paralysis of activity by the U.S. legislature. Anyway, he led the effort to stymie that legislation. So unfortunately, the problem didn't go away. And in 2001, a Republican got elected to be president. That was George W. Bush. They held the House and Senate, except that in 2001, 4 months into that year, there was a defection by the senator from Vermont, a guy named Jeffords, and he defected away from the Republican Party, so they no longer had a majority. So 2 years later, there was a shift in the Senate, and now everything was Republican. As I said, the problem didn't go away. So the question then, they were getting tremendous pressure from elderly people because drugs were getting more and more expensive to do something. So that resulted in uh, the Medicare Modernization Act of 2003, adding a prescription drug benefit to Medicare. I'll get to that in a minute. But there was more to the bill, and it did several other things. It changed the name of the Medicare subcontracting program from the not very sexy Medicare C or Medicare Plus Choice to Medicare Advantage. The public relations benefit of having that name rather than Medicare Part C was enormous. And that was the beginning of the benefit to the Medicare Advantage system. They changed the system that CMS used to determine what the capitated prepaid amount of money that these plans would get, the Medicare Advantage plans were going to get, to a risk-based system, which was enacted in 2006. The reason they did that was because prior to that, they were paying Medicare Advantage plans 95% of the average cost of Medicare patients. But the insurance companies were able to find people who were way more than 5% less costly. So they were picking out healthy people to insure by advertising in the business pages of the Wall Street Journal rather than advertising going to a nursing home and telling all the nursing home patients that, please enroll in our Medicare Advantage plan. So they were picking out really a generally very healthy population to insure. So Medicare said, well, we're finally going to change this and we're going to create a risk-based system. Within 1 year, they figured out how to game that system. And you've seen both Drs. Will Handler and I, a few weeks earlier, talked about the strategies that the companies use to game the system and profiteer off the Medicare Advantage program. Anyway, so that was done then, the risk-based system. And then they added coverage for preventive care, vaccines, and cancer screening. They also boosted the Part B and Part D premiums for the wealthy, income adjusting them. And I just want to say that we saw this in one of the countries, Italy, where you pay copays only if you're wealthy and not if you're not wealthy. And the copays end up being a meaningful part of the funding of Italy. You could do that, and that's a little progressive because the wealthy people want to pay, can pay more. But you could also just have a progressive tax to fund the whole system and not have a lot of copays and deductibles, which are administratively complicated. Anyway, this happened, and the disadvantages that may decrease the support for the system among the wealthy, but that's a theoretical issue, but that's what happened. They boosted Part B and Part D premiums for wealthy people, so that it would be income sensitive. So now, and I just want to say the word modernization was because there was preventive care, and it was a plan which was supposed to be modern. So the word modernization meant there was like a plan, and we like privatization, and preventive care was notably missing from Medicare. But if you look at the act from a financial standpoint, 99.9% of the funding within the bill was for the prescription drug benefit. What makes that statement inaccurate is that they actually started paying more to the Medicare Advantage plans for a variety of reasons. But really, the main part of the bill financially was the drug plan. So you had different ways to get the drug benefit. One was through a Medicare Advantage plan, which encompassed prescription drugs. In other words, the government will be paying some of the Medicare Advantage plans that wanted to provide a drug benefit, they would pay them extra to provide the drug benefit. Or alternatively, a patient could enroll in the new Medicare Part D program, which was going to cover prescription drugs, or they could do neither. And if later on they decided to enroll, there would be an indefinite penalty for the rest of their life for each year's premium. So the Part D program was not going to Medicare was not going to negotiate down drug prices. Instead, the price negotiation and the entire benefit would be administered by 40 private insurance companies, which were going to use PBMs, who would have no meaningful negotiating power against the pharmaceutical companies to actually drive prices down. So they balkanized the purchasers of drugs to many companies. There's now hundreds across the country, which have no marketing power against the pharmaceutical industry. Most of the private insurers were for profit, siphoning off more money in the form of profit. And the largest insurers are heavily involved in that benefit. The benefit itself is actually very complicated with a big gap in coverage, which immediately got the term the donut hole. And this fellow in the picture is scratching his head because he cannot figure out why all of this stuff was done to make the plan less useful, more expensive for taxpayers. So this guy scratching his head, he's just justified. And well, later we'll get to public support for the system. This slide, I just want to say, I didn't create a slide with with the original benefit. It's, but the basic structure is still the same today. And I thought I would include the one today because you're going to practice medicine today and not in 2006 when it was implemented. So this is the way this benefit structure works. And I'll go through it in 2024. So an elderly person who's enrolled in Medicare D, and I just want to say that one of the striking things, I pay for Medicare D, and I have to say one of the most striking things is that my premium to get into Medicare D is almost nothing. It's $6 for the entire year. And it was only $18 last year. And this is because I think I have really crappy coverage for very expensive drugs. So I'm not sick now. I'm hoping I won't get sick by the end of the year. But there are other plans that cost like $50 a month, which would get me up to 600 or 800, even more a year in some of these plans. I guess they have better coverage. It's really weird. Also, all I can say, I've never seen that kind of variability in the entry across the premiums. Anyway, it is what it is. And once you bought the benefit and you pay your premiums, and you have to contract this out yourself. I have to tell you, when I wanted to sign up for Medicare D, when I was first signing up for Medicare B, because you actively have to sign up for Medicare B within 3 months of your 65th birthday. That's a requirement, or you then get penalized for the rest of your life. For B, and that's the huge outpatient benefit. Okay, so at least when I went down to the Social Security office to enroll in Medicare B and make sure I was enrolled in Medicare A, I then said to them, this was, a couple years ago. So I then said to them, you haven't mentioned Medicare D, the drug benefit. I want to enroll. And she said, okay, you can do that. I said to her, why didn't you mention it and remind me that I should enroll? She said, I'm not legally allowed to even mention it. I have no understanding of that at all. And to this day, I still don't. I think it has to do with not if they mentioned it. I think that insurance companies were worried that you would then mention too much and you would steer them toward one of the 40 or hundreds of private companies instead of, leaving it a completely open playing field. I have no other understanding of that. Or they wanted me to miss the deadline and pay more for the rest of my life. I have no idea. Anyway, so that happened. So the way the benefit works is if you sign up and pay your premium, there's a $545 deductible, meaning you pay 100% of the first $545 of prescription drug each year. And I just have to say that there some stuff that's exempted, like vaccines, many vaccines. I don't think all of them, or maybe all of them by now. Anyway, so that doesn't count toward the deductible. But if a vaccine costs the government $100, I have to pay $545 beyond that because that's not included. I still have to pay $545 before I get any coverage. At that point, in the initial coverage phase, I pay 25% and the plan pays 75%. up to $5,030. So in other words, if my costs are going to exceed $5,030, I've already paid 545 plus a quarter of 4,500. So that's $1,200. So uh, that's 1,800, 17 or $1,800 if my drug spending were 5,030. And I just want to say that 5,030, that's the asking price the pharmaceutical companies are asking. And that the Medicare insurance plan the D insurance plan has tried to negotiate down. So that's the final result of what I'm paying. Okay, so if I get beyond that $5,030 of drug spending that year, then between 5,030 and 12,447, the enrollees pay 25% still. And that used to be 95%, which was why it was called a donut hole. But subsequent to the passage of the plan, it's now 5% covered by the plan. Don't ask me why. And 70%, the drug companies themselves are supposed to give enough of a discount so that it represents a 70% price discount. I just want to say, can somebody guess what that motivates the drug companies to do with the price of the drug?
Probably just raise the price.
You got it. Absolutely. So they raise the price. Maybe they triple it so that when they're reducing 70%, they get what they wanted in the first place. So this is like asking for pharmaceutical drug price inflation. Exactly. It's like boggles the mind. Anyway, so that's that. So far you've paid 25%. So now you've paid 25% of another $7,000, and you're up to, I don't know, say 5,000 or spending out of your pocket or something like that. And then finally you get a catastrophic coverage. I think in the original legislation, you had to pay 5%, and it looks like now they've gotten rid of the patient having to pay anything. So now the plans pay 20% beyond $12,447, and that 80% is a lot of money for cancer patients. And I'm going to tell you right now, I don't understand that. And I worked on this last night. I don't understand it. And if I had to try to look on the internet as to what that actually means, I wouldn't even know how to ask the question. So I am admitting ignorance. It's probably a lot of money for these expensive patients. I don't know what they mean by Medicare covering it, because Medicare is already paying the plans a lot of money to provide this benefit. So I don't know if they're billing Medicare directly, because Medicare doesn't set or even negotiate prices. So I'll try to look this up over the next week. I'm sorry I didn't have time yesterday, but I don't understand this. One way to do it would be just pay a higher amount to the plan to start with and have the plan cover it. I'm just not sure, but it's very confusing to me to see that. And I guess what bothers me especially is that the plans are not going to be successful at negotiating down drug prices. Medicare is not allowed to do it. So now Medicare is evidently going to be spending 80% of these very inflated costs that it did nothing to negotiate down. So it looks to me like one way or another, the taxpayers are getting pretty badly ripped off, especially with, as Nehemiah pointed out, we've already incentivized them to drastically raise the price. All right. So then they did opinion polling of this plan after it was passed, and 26% approved, 47% disapproved, and 27% didn't know or were uncertain. I have to tell you, the senior citizens have been wanting a drug benefit for years, and now they had one. And the fact that so many people disapproved it spoke to the donut hole in the benefit, that it was a pretty sketchy benefit, and all of the money that went into it. So a guy, I should put his picture on a slide, but a guy named Towson, who was the chief congressional negotiator, Republican from Louisiana, Within a couple years of this bill passing, he left Congress to take a $2 million a year job as the chief lobbyist for the pharmaceutical industry lobby. So that's the kind of stuff that was happening with this plan. And other people took drugs with the insurance companies, which are now going to make even more profit over the program. So there was a meaningful amount of bad publicity. After years of fierce campaigning, lobbying, and legislating over the issue, a landmark agreement finally emerged in Congress to provide Medicare prescription drug benefits in Medicare. Among the key stakeholders in the legislation, there were definite winners and losers, but the group that should have come out on top, the senior citizens, were reeling and confused at the prospect of limited help while watching industry groups count their booty. In fact, members of Congress from both parties contended that some seniors struggling to pay for prescription drugs may actually be worse off than they were now. And the reason that could happen is they may no longer qualify for Medicaid. And many states have prescription drug assistance programs. So anyway, so that's sort of the upshot of what happened. And you can see that one of the reasons it happened this way is that the most profitable sector of the healthcare economy is pharmaceuticals.